Welcome to Goodnight Dentistry at Codis Dental.
Hello, my name is Dr. Ron Cox. The purpose of this video is to demonstrate what is normal and what is not in regards to snoring, sleep apnea, and your airway. In this video, we will look at obstructive sleep apnea and what that looks like, what a sleep test is, why it is important, what kind of treatment are available and how they compare. Why do I feel the way I do? Those are some of the things we're going to address today. Let's start with why you are here. Some of you are here because you snore or your partner does. This may be affecting your partner or it may be causing relationship issues. Others may suspect that you or your partner have sleep apnea and it's a health concern. Another group may have been diagnosed with sleep apnea and you're looking for an acceptable alternative to control it. This is the right place to find answers to those questions. Oral appliances are the first-line treatment for CPAP intolerant, those that can't or won't use CPAP. We can treat people with primary snoring, those that do not have sleep apnea, they only snore. And we also are for people that had a sleep study, had a negative outcome, and yet they have all the signs and symptoms of sleep apnea. We can treat all those groups. Let's begin with what is normal. People ask me if snoring is normal. The answer is no. Snoring is common. The American Academy of Sleep Medicine estimated that 90 million people snore in the USA. Of those 90 million people, about 50 million have some level of sleep apnea. We're only diagnosing about 10% of those. You can have snoring without sleep apnea, called primary snoring, but it can also be a sign of sleep apnea. What actually is normal? Quiet. A linear airflow is actually quiet. So when we sleep, it should be quiet. When there is a disturbance in the airflow pattern, it causes tissue vibration, and that's the snoring that we hear. People that snore loudly may have a range of over 100 decibels. We're speaking at about 45 to 50 decibels right now. That 100 decibel range is equivalent to sleeping next to a jackhammer or an airport. This can cause hearing loss for your partner as well. So, are you here for sleep apnea? Maybe. What is sleep apnea? What is sleep apnea? By definition, it is a 90% reduction in airflow. It has to last a minimum of 10 seconds. Basically, you stop breathing. A good analogy to remember this. Have you ever had a sundae or a thick shake drinking through one of those fat straws and enjoying it? Then the straw gets jammed into the ice cream. Suddenly, it just collapses. The harder you suck, the more it collapses. This is in a nutshell is an apnea. This is your diaphragm trying to pull oxygen down to your lungs, but the airway has collapsed, like the straw. The more the diaphragm works, the more the airway collapses. We will talk more about how we save ourselves and how we get out of the apnea a little later. The second definition I want to provide is a hypopnea. A hypopnea is a 70% reduction in airflow, also lasting a minimum of 10 seconds. And the scoring is also done by blood oxygen desaturation. It can be 3 or 4% depending on what they're looking for. There is a score you will hear about called AHI. This is the Apnea-Hypopnea Index, and it is no more than the number of times that you either have an apnea or a hypopnea in a sleep test. They divide that by the total time you slept, if it's a lab test, or the time that you turn the machine on or off, if it's a home test. Those are the two types of tests that can be used. The AHI is used by doctors so that we can speak to one another. It defines if you have sleep apnea or not. It also gives the level of severity so the doctor can decide how best to treat you. By definition, the average of less than 5 events per hour means you're normal. A mild case is defined as between 5 and 15 events. A moderate case is 15 to 30, and a severe case is someone that has over 30 events per hour, and I've seen well over 100 per hour in some patients. What this doesn't tell you is it doesn't describe oxygen desaturation. It doesn't talk about cardiovascular health. It doesn't tell you how symptomatic you are. I find that people on the lower end of the scale are more symptomatic than those on the severe end. It is merely a way to define the disease and how to treat it. So what does OSA actually look like? Well, it looks different for different people. For instance, my grandson at age 3 had sleep apnea. He was not growing well. He had sinus issues. He had dark circles under his eyes. He would grind his teeth. He would snore, and his mother would notice that he stopped breathing. And quite often these kids are misdiagnosed with ADHD. They are fussy just like kids that get overly tired. A young woman will present symptoms that are different. She may be the typical TMD patient, that's the temporal mandibular joint. She may have morning headaches and be misdiagnosed for migraines. She may be achy, misdiagnosed for fibromyalgia, and actually she may just need more of the deeper sleep to replenish her body. She may have anxiety or depression, and she may have insomnia. Typically, women will say, I'm chronically fatigued rather than I'm sleepy. The typical Pickwickian version of the older male, the one we think of having sleep apnea, is a little overweight, falls asleep easily, snores loudly, stops breathing, witnessed apneas. And the point is, you cannot look at someone and say you have sleep apnea. I've seen people who look like slender young models. I have athletic young males, and they have sleep apnea. You could be that child with sleep apnea, or you could be that older adult, either a male or postmenopausal woman. This is why the sleep study is necessary to define if you have sleep apnea or not. If you snore, we need to rule out whether you have sleep apnea or not, or whether it's just snoring. And I will tell you that to make these devices, we work under a physician's prescription, written by a physician, usually a sleep physician, or it can be your primary care physician with a sleep physician that reads the study. We have the study done and have a prescription in hand so that we can legally treat you. So the next question that comes up is, why do I feel the way I do? The answer is due to sleep fragmentation. We think that if we get 8 hours of sleep, we might reasonably expect to feel refreshed when we wake up, but not everybody does. I will tell you that in regards to signs and symptoms of people with sleep apnea, some are not overweight, some do not snore, some don't feel tired. But many people do wake up and feel unrested and chronically fatigued or sleepy all day. This can be due to the sleep fragmentation. It has to do with the stages of sleep. When we sleep, it is not one thing through the whole night. It runs in cycles of 90 to 120 minutes, and during that time we go from awake, like we are right now, down into deeper stages of sleep. While we are awake, the brain tells our lungs how deeply and often to breathe. It also tells the muscles that surround the airway to help the airway to stay open when we inhale. People with sleep apnea, if you have it, typically have a more collapsible airway than people that do not. Statistically, that airway is also half the diameter of someone that does not have sleep apnea. So when we are talking about sleep stages, how does that work? Just under awake, like we are now, is another stage of awake, and your brain is still engaged. Below that, we just wouldn't have a conversation. Below that, there are 2 stages of lighter sleep. The average adult spends 50% of the night in these stages. Think of them like junk food. You get enough calories to stay alive, but it's not very nutritious. The next stage would be N3 or slow wave sleep. This is when our bodies are replenished. My grandson was not getting enough growth hormone. Slow wave sleep is the stage where they get growth hormone. And now that he's been treated, he's starting to grow and he's doing quite a bit better. The last stage of deeper sleep is called REM. Most people have heard of rapid eye movement. And this is when the diaphragm works, but the other muscles do not, so we don't act out our dreams. This is mostly a protective mechanism unless you have sleep apnea. REM sleep occurs for the most part in the latter half of the night. During that time, you have no muscle tone to support the collapsible airway, so it may act like that straw in the ice cream sundae we described earlier. For this reason, we see most commonly people having strokes, heart attack, and sudden death, and it happens between 2 and 6 in the morning. That's the time when we have more of the REM sleep. If you have a heart condition and have a sleep apnea event, it may be hard for you to come out of it and you may not survive. What exactly happens when we have an apnea? This is your fight or flight response. That's what kicks in. We're not getting oxygen, the brain is aroused and activated, the sympathetic nervous system goes off, and we release adrenaline. By the way, if you happen to wake up in the middle of the night and can't go back to sleep for a while, it may be because it takes adrenaline a while to dissipate. The fight or flight response brings you up to a level of awareness that your brain can now re-engage, and therefore the muscles are reactivated, the airway will now open, and the diaphragm that can't do it by itself now has the help it needs, and you start breathing again. This process of awakening is enough to open that airway. However, you have to start the process of the sleep stages over again, from awake to lighter to deeper sleep. With each apneic event happening multiple times per hour, this process repeats. This is called sleep fragmentation. It leads to so much more time in lighter sleep and much less time in deeper sleep in the replenishing stages of slow wave sleep and REM sleep. The result of this is a decreased quality of life. Poor sleep by itself can cause weight gain, changes in the way we process sugars. We tend to crave foods with higher calories. Decreased slow wave sleep can cause us to have more body aches. We don't feel as good. The average adult gets 20% of the night in that slow wave stage. Older adults get less naturally. At my age, I'm lucky if I get 5% of the night. With sleep apnea, you may have a diminished amount of time in slow wave sleep or none at all. Note, fit young females can often be misdiagnosed with fibromyalgia. It may be that their aches and pains are due to lack of sleep from this fragmented sleep pattern. A decrease in REM sleep affects memory and our ability to work out the issues of the day. This can lead to a lack of focus, increased accidents, anxiety, or depression. Your spouse also may be affected by this in these same ways because they often wake up when you do during repeated apneic events, when you stop breathing, or just from loud snoring. Other signs and symptoms you may see include TMD, the temporomandibular dysfunction. Young females are most frequently seen within this category. Chronic fatigue or excess daytime sleepiness. Mood disorders like anxiety or depression. Acid reflux from respiratory effort during those apneic events. The diaphragm can pull up stomach acid, and typically this is seen at night or first thing in the morning. Nocturia, this is when you get up frequently for bathroom visits. All these are related to OSA. Morning headaches due to oxygen desaturation or posturing your head by elevating it so you can breathe better while you sleep. Headaches typically will occur from this in the forehead and last for about 2 hours in the morning. Insomnia is another sign. It is seen frequently. Most people with sleep apnea have sleep onset in less than 15 minutes, but my average patient is much sooner than that. People with sleep apnea may have trouble going to sleep, subconsciously knowing they're going to be in a fight. Or they may wake up, as I said, for no reason between the hours of 12 and 6 in the morning. They're wide awake for long periods of time and they're unable to return to sleep. If you think you have sleep apnea, there are many reasons to be concerned. Sleep apnea is statistically linked to bad comorbidities such as hypertension, high blood pressure, stroke, heart attack, sudden cardiac arrest, atherosclerosis, that's hardening of the arteries, AFib, diabetes type 2, dementia, Alzheimer's, erectile dysfunction, sexual dysfunction, low libido, and oxidative stress, which is a scientific way of saying aging, especially the skin. I will stop here with this overview of sleep apnea and primary snoring. My assistant will be in shortly to talk to you about your experience with OSA or snoring and to gather some additional information. After that, I will be in to see you. We will continue this with more about oral appliances, how they work, how they compare to CPAP, and what they look like. I will try to answer all your questions and if at that time.